Once again, thank you for this invitation. And my second lecture is about delivery room handling of the newborn. And here are my disclosures. And I put up 3 learning objectives for this lecture. First of all, it is to understand the newborn resuscitation algorithm. And I also want to discuss the effect of delayed cord clamping and also heat loss prevention and hypothermia therapy. Specifically, I would like at the end to talk about the so-called Helix Trial, which has created a huge debate about the hypothermia therapy in low-income countries. Well, talking about delivery room management or handling, there are a number of topics we could cover, and I listed many of them here. And I don't have time to penetrate these in depth during these 30 years, but I will touch many of these. So when we discuss delivery room management, we also very often talk about the golden minute or the golden minutes. And the reason for that is that what we do with, for instance, asphyxiated newborn infants in the delivery room, and here I listed some of the procedures we are applying to these babies. So what we do during these minutes may be very important for the outcome, the rest of the life for these babies. Of course, postnatal care is also important, and also antenatal care. And I will mention a few maternal and antenatal factors we should consider. First of all, we know that perinatal death, not only perinatal mortality, but also newborn and infant mortality increases with increasing BMI. So it's important to inform young women and even girls that they should keep their BMI within normal ranges before they become pregnant. We also know that antenatal steroids, in the case of threatened premature labor, may reduce mortality. And here are data from the European database eNewborn, where we have almost 40,000 babies born between 22 and 32 weeks of gestation. And what you can see here is that a complete course of antenatal steroids reduces mortality with more than 50%, but even an incomplete course does the same. So this is important to remember. Now, of course, there's a new discussion about the effect of antenatal steroids in low and middle income countries, and it may not be as efficient as we have believed up to now, but that's another discussion. C-section rate is also important for the outcome, and it has been shown that if the C-section rate in a country exceeds approximately 10%, there's no or very little effect on mortality. So it seems that perhaps the optimal C-section rate is between 10 and 15, or maybe up to 20%. This is important because we know that many countries in this world have a very high C-section rate. And we know that it matters because if a baby is born before 40 weeks, morbidity increases. And this is illustrated here by looking at so-called serious respiratory morbidity. You see at 37 weeks, C-section versus vaginal is extremely high. And even up to 39 weeks, C-section versus vaginal delivery increases morbidity. So I think it is important that we keep the C-section rate at reasonable level. So what is the need of resuscitation? Again, I will show you data from the European database in newborn, and here you see we show that the smallest babies, the immature babies, almost 100% of these needs resuscitation at birth, and then it drops to still more than 50% for 32 weeks. But we have to distinguish between basic resuscitation and advanced resuscitation. In basic resuscitation, we define as the use of bag and mask ventilation and oxygen if needed, and you see that very few of the immature babies need basic resuscitation, but more 32 weeks need that. But when it comes to advanced resuscitation, we see that most of the immature babies would need advanced resuscitation. And this is defined as bag and mask plus oxygenation, intubation, chest compressions, and adrenaline if needed. And is this of interest? Yes, it is, because we have shown that mortality is not increased in babies in need of basic resuscitation. But as soon as they need advanced resuscitation, we see that mortality is increased almost twofold. So this is the ILCOR neonatal resuscitation algorithm. And this is from the guidelines from 2010. And in 2010, the so-called golden minute was introduced here. Before that, they had timed every event by 30 seconds intervals, but now it was simplified. But the golden minute was introduced. But the question is, when is the golden minute? And ILCOR didn't define that. And when you look into the literature or ask people, you see that there are different practices when you start a clock. I think we should agree on this definition. The baby is born as soon as the whole baby is out, and then we start the clock. And this is, of course, extremely important to agree upon when we now talk about the golden minute, the first 60 seconds after birth. And we also do the APGAR scoring at 1 minute and 5 minutes. So we have to know what we are doing. Is it realistic to achieve this, the golden minute? Well, we recently published this small review about some studies that had been published using the so-called Helping Babies Breathe algorithm. And you see this study from Tanzania, published 4 years ago. You see that time to obtain the first ventilation with bag mask was in mean 134 seconds. That's 2 minutes and 14 seconds, way beyond the golden minute. This study here from Uganda, they're better, very close to golden minute, 68 seconds, and also from Nepal, 71 seconds. And again, the same group from Tanzania, 109 seconds. So they're not able to follow the algorithm of Helping Babies Breathe, but it is possible, at least for most or many babies, to start ventilation within the first minute of life. So if we go back to the ILCOR recommendations, the first 30 seconds, the baby should be dried, kept warm. It should be wrapped into plastic if it's less than 28 weeks gestation, and stimulated to breathe if that is needed. We know that 15% of all babies would need stimulation to start breathing. The airway should be positioned correctly, and the heart rate and breathing rate should be recorded. If the baby needs respiratory support, this should be established within 60 seconds. And if you have a pulse oximeter, it should be on within the first minute of life. So there are some changes in the algorithm from 2010 to 2015. They are revised every 5th year. And you see here now that the golden minute in 2010, it was split up in 2 halves. Each 30 seconds. Now it's only one line here. And then this new temperature line was introduced, reminding us how important it is to keep the baby warm during the resuscitation. So we published a review of the 2015 ILCOR guidelines together with Nicky Roberts and Max Vento. Published that, and we were a little bit disappointed regarding these guidelines because we found they were not so complete. We needed to remember the 2010 recommendations because they were not repeated in 2015. And these guidelines also introduced ECG and suggested to use ECG for heart rate assessment instead of stethoscopy. CPAP for term infants was recommended, but it was not evidence-based at that time, at least. And we were also worried about using a combination of plastic wrapping and thermal mattresses for the most immature babies, because that may induce overheating. And ILCOR also recommended the use of therapeutic hypothermia in low resource settings. But in our opinion, this was not evidence-based. In addition, the use of passive cooling by ice packs may result in overcooling. So we were not so satisfied with the 2015 ILCOR guidelines. Now, in 2020, a revised version came out. And again, together with Nicky Roberts and Max Vento, we reviewed this. And what you can see here is that there are one new recommendation and 5 procedures had been changed. So the new recommendation was that it was recommended to do briefing and debriefing after resuscitation. And then there was some modifications regarding handling of non-vigorous delivered babies through meconium amniotic fluid. Sustained inflation was not recommended in preterm babies, and there were some adjustments regarding epinephrine. For instance, if there was no intravascular access, it was now again recommended to use the intratracheal route, but then with a higher dose. And regarding vascular access, umbilical venous catheterization is recommended as a primary mode, but if you don't have access there, the intraosseous route is a feasible alternative. What also was new was that if there was no return of spontaneous circulation within 20 minutes, then you should discuss or ILCOR suggests that you should start discussing of discontinuing resuscitative efforts. In the old guidelines, you remember that they said after 10 minutes you could stop or consider to stop. And I think the present guidelines on this issue is much better. But what you also can see that all these recommendations are based on none or very weak or low evidence. So this indicates that there's a lot of work to do before we really have evidence-based recommendations. A few words about heart rate assessment at birth. We know that heart rate by auscultation is inaccurate and underestimates the heart rate obtained by ECG. But to compensate for that, together with Roger Soll, we suggested that if the heart rate is counted 10 instead of 6 seconds, much of this inaccuracy could be eliminated. We also know that a reliable heart rate is obtained earlier with ECG than with pulse oximetry. In one study, the difference was 84 seconds. But we also know that quite a few of the ECG signals are excluded due to technical problems. And we also have a problem with so-called pulseless electrical activity in animal models. It has been shown that a very high percentage of the signals are PEA. So we hope for new devices, and we know that there are new devices under development, for instance, based on Bluetooth technology and other technologies. But in 2016, Roger Soll and I, we declared that we think that auscultation is still the gold standard for auscultation for assessment of the heart rate at birth, and I think that is still valid. So, cord clamping. Today, most international organizations in this field, they recommend delayed cord clamping, especially in preterm babies, and they recommend about 60 seconds. You see some variation between the different declarations, and some said at least you should wait 60 seconds. And the reason for that is that within 60 seconds, approximately 70% of the blood from the placenta, which is transfused to the baby, has reached the baby. So there's not so much to gain if we wait another minute, for instance. Now, of course, we talk about physiological cord clamping. That means that you should ventilate before you cut the cord. And here is a study from Stuart Hooper, an animal study from Stuart Hooper in Melbourne, showing what happens if you clamp the cord before the onset of ventilation. You see arterial blood pressure goes up like this. Carotid arterial blood flow also increases. By contrast, if you clamp the cord after ventilation has been initiated, you see that there's a very smooth, there's absolutely no increase in arterial blood pressure, and also carotid arterial blood flow is very stable. Is there any risk for delayed cord clamping, as overtransfusion, polycythemia, jaundice, hypothermia, persistent pulmonary hypertension, delayed resuscitation? Well, recently Bruckner and co-workers summarized this, and they recommend that one should practice delayed cord clamping in healthy term infants for at least 60 seconds in high environments units, and for at least 180 seconds in limited resource environments. And they also tell that delayed cord clamping reduces incidence of anemia and iron deficiency, improves hemodynamic parameters, and there is no evidence that delayed cord clamping results in higher rates of phototherapy. We know from studies that, of course, there is an increased incidence of polycythemia, but it's probably most often asymptomatic. Regarding growth retarded newborns and monochorionic twins, we need more evidence before we can give recommendations for delayed cord clamping or not. So here we have summarized some of the differences between immediate cord clamping and delayed or deferred cord clamping. Regarding oxygenation, you see that the saturation are higher the first minutes of life with delayed cord clamping. You see preductal saturations are lower with immediate cord clamping. As you can see here, we try to illustrate here. What about cord milking? For instance, if you cut the cord about 25 centimeters from the umbilicus, and this should be done within 30 seconds after birth, and then you should milk the cord at a speed of 10 centimeters per second. Well, Katerina and co-workers have published data from immature babies showing that cord milking in these babies compared with delayed cord clamping increases severe intraventricular hemorrhage 4, 5, 6-fold. So it's a dramatic increase in severe intraventricular hemorrhage. So what happens when you milk the cord? You increase the venous return to the right atrium, and blood enters the foraminal valley and the aorta up to the brain. And if you have pulmonary vasoconstriction and there is lack of cerebral autoregulation, and there is a right to left ductal shunt, this may result in fluctuations in flow. And we know that an immature brain has a very fragile germinal matrix. This may lead to intraventricular hemorrhage. Few words about the chest compressions and adrenaline. And this, which we're about to publish, showing that if you give epinephrine during resuscitation, the dosage is 0.003 milligram per kilo, and you flush with only 1 ml of saline, 43% receives return of spontaneous circulation after 1 dose, and the median time to get return of spontaneous circulation is 95 seconds. If you flush with 2.5 ml, 80% receives spontaneous circulation after first dose, and median time is 72 seconds. But if you flush with 10 ml, 3 milliliter per kilo, 90% get back the spontaneous circulation after first dose, and the median time is now 39 seconds. So we recommend to flush with more than 1 milliliter, and probably you should use approximately 3 ml per kilo by flushing. How should you oxygenate the baby during chest compressions? Which FiO2 should be applied, and how should we wean if you use 100% oxygen during chest compression? Should you wean rapidly or gradually when return of spontaneous circulation is achieved? Well, if you look at the recommendation by the NRP in US, they state that it may be reasonable to increase inspired oxygen to 100% if there was no response to positive pressure ventilation with lower concentrations. And once return of spontaneous circulation is achieved, the supplemental oxygen concentration may be decreased to target the physiological level based on pulse oximetry to reduce the risks associated with hyperoxia. Now, very recently, Sankaran in Satya and Lakshman Rushima's group in US, they tested this out in animal studies, and what they found was that if you wean immediately to air, cerebral oxygen delivery reaches the target very quickly, within approximately 1 minute. However, if you wean gradually as recommended, you see that there is a very high oxygen delivery for up to almost 15-30 minutes. And it has been shown that even if you use 100% oxygen during chest compressions, the oxygen saturation and PO2s are low. So we think that it is important to wean quickly to room air as soon as spontaneous circulation is achieved. Heat loss. As I mentioned, Ilka now emphasizes the importance of maintaining the temperature. And for immature babies, in order to prevent heat loss, the babies are covered with an occlusive wrap or put into plastic bags immediately after birth without drying them. And this reduces the incidence of hypothermia and hopefully result in decreased morbidity and mortality. However, a systematic review, a Cochrane review, which was published by McCall and co-workers in 2018, 3 years ago, didn't find any difference regarding major brain injury, whether you wrap the babies into plastic or not. And when they looked at mortality, again, there was no effect of wrapping into plastic. So this is, of course, disappointing. Still, we think it is important to maintain the temperature. Very recently, this study regarding early kangaroo mother care for low birth weight infants was published in New England Journal of Medicine, and it shows that early kangaroo mother care reduces mortality, and the number needed to treat to prevent one neonatal death is 27. And this study was carried out in Ghana, India, Malawi, Nigeria, and Tanzania. So this is highly recommendable. Then I will end talking about the so-called Helix Trial, which is a hypothermia therapy trial in 3 countries, India, Sri Lanka, and Bangladesh. And this study was published last week, and has created a lot of debate already. So in this study, babies with low and moderate hypoxic ischemic encephalopathy, more than 36 weeks or 1.8 kilo, were randomized to receive hypothermia therapy or controls. And you can see that they were quite successful in reducing the body temperature to the goal of 33.5. And after 72 hours, the babies were rewarmed, and you see they were very successful in this procedure. However, when they looked at the outcome of these babies at the age of 18 to 22 months, what I found was that mortality was significantly higher in the hypothermia treated babies, 42% versus 31%. And this, of course, created a lot of discussion. Here is a Kaplan-Meier plot demonstrating basically the same, that babies who were treated with hypothermia, they died earlier and they had a higher mortality. And so here's the summary of all the centers of the data from the Helix trial. And you see that if you cool the baby, you have a higher mortality. So the risk of surviving is 50% higher if you don't cool the baby, if you practice what they call usual care. Now, this has created a lot of discussion. And very recently, this paper came out with the title, The Rise and Fall of Therapeutic Hypothermia in Low-Resource Settings, Lessons from the Helix Trial. Because these data from the Helix Trial, of course, represent a threat to the use of hypothermia in many low-income countries in Africa and other places around the world. So in this article, the authors were quite harsh and stating that generation of high-quality research data alone are not sufficient. It is important that low and middle-income countries clinicians have the necessary skills to interpret these data and use it in their clinical practice without being influenced by industry lobbying or stakeholders with vested interests. I took myself part in a Zoom meeting about this study from South Africa 2 weeks ago, and I think this study has really created a lot of debate. So this is, if you look at the data before the Helix trial, it shows that it favors, this is a meta-analysis of all the studies, it favors cooling. So why does the Helix trial show the opposite? I think the subject is not settled yet, but I think also it illustrates that you cannot translate research results from high-income countries to low-income countries because they have a different situation and the babies are different. So I think that is an important lesson. So in a summary, we recently published this article about delivery room management of asphyxiated term and near-term infants. And here we have listed a number of the topics which are of interest for recitation and delivery room handling. I don't have time to go through all this. What we have tried to do is that we have tried to specify differences between low resource settings and high resource settings regarding all these topics. So if you're interested, you can read this. Of course, there are a lot we can discuss here. And when I'm rereading this, although this is a very, very new article, I see that maybe I would have phrased some of the recommendations differently already. So here are the references you can read for those who are interested. These are quite recent articles we have published. So with this, I would like to thank you for your attention, and